I want you to think about um, exactly what you're doing right now.
Yeah, take a second and just sort of scan your environment.
Right, because you are listening to this deep dive, and chances are you are sitting down.
Most likely, yeah.
Maybe you're, slouched back in a really comfortable desk chair, or maybe you're relaxing on the couch.
Or lying in bed.
Exactly. And it feels incredibly relaxing, right? It feels like you
Yeah.
are giving your body this well-deserved, peaceful break.
It does feel like that.
But beneath the surface, that simple lack of movement is actually sending these immediate, chaotic signals to every single major system in your human body.
It really is a physiological alarm bell
Wow.
because we culturally equate stillness with rest.
Yeah.
And we equate rest with healing.
Right, like get some rest and you'll feel better.
Exactly. But your biology just doesn't see it that way at all.
See, it doesn't.
No, the human body interprets extended stillness not as a vacation, but as a fundamental breakdown of its environment.
So it's panicking.
Pretty much. If you aren't moving, your body assumes something is catastrophically wrong.
And that is exactly our mission today. We are looking at this fascinating, really deep collection of clinical notes, anatomical lectures, and mobility curricula.
Yeah, specifically the intensive material used to train healthcare professionals.
Right, on the literal physical mechanics of human movement. But more importantly, we're going to explore the shocking, rapid breakdown that occurs during immobility.
The stuff that happens when you just stop.
Exactly. Our goal today is to understand not just the engineering of how you move, but why movement is quite literally the ultimate medicine.
And, well, the terrifying full-body domino effect that gets triggered the moment you stop.
Okay, let's unpack this. Let's start with the basic blueprint of how we actually manage to move in the first place.
Well, to truly grasp the breakdown, we first have to respect the machinery.
The hardware.
Right. Human movement isn't just, a muscle flexing. It relies on a triad.
A triad?
Yeah, it's this constant, high-speed, real-time collaboration between three major biological systems.
Okay, what's the first one?
First, you have the skeletal system. These are your bones, cartilage, ligaments, and tendons.
A hard framework.
Exactly. But they aren't just dead scaffolding, right? Bones are actually living factories.
I feel like we forget that. We picture Halloween skeletons.
Oh, totally. But they protect your internal organs, sure, but they also produce your red and white blood cells deep down in their marrow.
Wow.
And they act as the body's primary storage vault for vital mineral salts, specifically calcium and fat.
So they are the structural scaffolding, but also the supply chain?
Precisely. Then, layered directly onto that scaffolding, you have the muscular system.
Meat.
The meat, yeah. The skeletal muscles cross over the joints and attach to the bones via tendons.
Right?
So when a muscle contracts, it actively pulls on that bone to generate the mechanical force you need to actually move.
Okay, so bones and muscles. What's the third part?
The third part of this triad is the one that, well, so often gets overlooked. But biologically speaking, it is the absolute dictator of the entire operation.
The nervous system.
Yes, the nervous system.
Because when you look at the raw anatomy, it becomes incredibly clear that you can have the skeletal framework of, like, an Olympic weightlifter.
Oh, yeah.
And muscles built like a Greek god. But absolutely none of it matters if the nervous system isn't functioning flawlessly.
What's fascinating here is how delicate and unforgiving that command and control system actually is.
Right.
Let's look at a specific anatomical bottleneck, like the brachial plexus.
Okay, what is that?
It's this complex, braided network of nerves that exits your spinal cord right at the base of your neck.
Ah, okay.
And it threads down through your armpit to supply all the electrical signals to your shoulder, your arm, and your hand.
So it's the main power cable for the arm.
Exactly. Structurally speaking, you could have a perfectly healthy arm. The biceps are strong. The humerus bone is intact.
But if that nerve network gets damaged...
If that specific nerve network in the shoulder gets pinched or damaged, that arm simply will not move. The spinal cord and the peripheral nerves are the ultimate gatekeepers of mobility.
You know, it makes me think of the human body like a massive state-of-the-art construction crane.
Oh, I like that.
Yeah, like the bones are the heavy steel beams giving it shape and structure.
Right.
And the muscles are the thick, braided steel cables and hydraulic pulleys that actually generate the lifting force.
Yeah, that's
But the nervous system, that's the operator sitting up in the little cab with the joysticks.
sending all the electrical signals down the wires.
Exactly. If that operator falls asleep, or if someone takes like a pair of wire cutters to the cables connecting the joysticks to the hydraulics.
Which is essentially what nerve damage is, by the way.
Right. Then that multi-ton piece of machinery is completely, hopelessly useless no matter how strong the steel is.
That is a brilliant analogy. And, when that operator is awake and the wires are intact, that massive machine has to operate based on 4 main pillars of body mechanics.
Okay, the 4 pillars.
Yeah, these are essentially the laws of physics applied to the musculoskeletal system to keep it from, well, destroying itself.
Good goal. What's pillar number 1?
The first pillar is body alignment. We casually call this good posture.
Sit up straight, don't slouch.
Exactly. But biomechanically, it's about holding your joints in a neutral, stacked position.
So gravity pulls straight down.
Right, straight down through your center of mass. That means no single joint, tendon, or muscle group is bearing an unfair share of the load.
Right, because if your alignment is off, say your head is pushed forward from, staring at a phone all day.
Which we all do.
Right. Then the muscles in the back of your neck have to work overtime, pulling constantly, just to keep your head from falling into your lap.
Yeah, and everything else has to compensate for that.
Okay, what's the second pillar?
The second pillar is balance. In clinical mechanics, balance requires a very specific physical base of support.
Okay.
To be perfectly stable, you want your feet spread apart, ideally about 8 to 10 inches.
8 to 10 inches.
Yeah, you place one foot slightly in front of the other, and you bend your knees just slightly.
Okay, let me push back on that specific number for a second.
Sure.
Why exactly 8 to 10 inches? Why not a super wide stance, like 2 feet apart?
Like sumo wrestler.
Yeah. Wouldn't a wider base make you even more stable, like a pyramid?
It's a great question. So, if your feet are too close together, say 2 inches apart, your base of support is incredibly narrow.
Right. A slight push will topple you over.
Exactly. Your center of gravity easily goes outside that base. But if you go too wide, say 2 or 3 feet apart, you actually sacrifice mobility for stability.
How so?
Well, your leg muscles are now splayed outward, meaning you can't easily step forward or backward without first awkwardly shifting your entire body weight.
Oh, I see. You're stuck.
Right. 8 to 10 inches roughly mirrors the width of the human pelvis.
Oh, that makes sense.
It aligns your femur bones directly under your hip sockets. That gives you maximum structural support while still allowing you to instantly engage the leg muscles for movement.
So it's the perfect sweet spot between being a solid pyramid and still being able to actually, walk.
Exactly. Now, the third pillar is coordination.
The operator in the cab.
Yes. That's the smooth, sequential firing of the nervous system and the muscles.
Pulling the levers in the exact right sequence so the crane doesn't jerk violently and drop the load.
Precisely. When you lift something, your nervous system has to calculate exactly when to fire the calf muscles, then the quads, then the glutes, then the shoulders.
Working in perfect fluid synchronization.
Yeah. And the fourth pillar is joint mobility.
The hinges.
Right. It's the actual physical ability of the hinges in the machine to open and close smoothly through their full range of motion.
So when we put these 4 pillars into practice, especially in a demanding environment like clinical care or heavy physical labor, the protocols dictate a very strict approach to lifting.
Almost mathematical, yeah.
You maintain that pelvic width base of support. You always bend from the hips and the knees to lower your center of gravity.
And you never, ever bend at the waist.
Because your lower lumbar spine is absolutely not engineered to be the primary fulcrum for a heavy load.
It's really not. It is designed for flexibility and supporting the upper body's static weight, not for deadlifting.
Right.
When you bend at the waist to pick something up, you are isolating these tiny erector muscles in your lower back.
And those fragile discs between your vertebrae.
Exactly. You're asking them to do the job of the massive quadriceps and glutes.
It's like using a screwdriver to hammer a nail.
It's a recipe for disaster.
But I do want to ask for some clarification on another lifting rule from the notes.
Go for it.
The clinical protocols heavily emphasize that you must carry heavy objects as close to your body as physically possible.
Yes, rule number 1.
I think everyone has heard this, but why does it matter so much? I mean, if I'm holding a 20-pound box, it's 20 pounds whether it's clutched to my chest or held out with my arms fully extended.
The mass doesn't change, right?
Exactly. The mass is the same. Why does an extra 12 inches of distance make that box feel 10 times heavier and threaten to, blow out a spinal disc?
This all comes down to the physics of leverage, torque, and your center of gravity.
Okay.
Think of your body as a seesaw. And your lower spine is the pivot point, the fulcrum.
All right, I'm picturing a seesaw.
When you hold a weight away from your body, your arms become a long lever arm. Physics dictates that the further a weight is from the fulcrum, the more rotational force or torque it exerts on that pivot point.
Okay, so it's a multiplier effect.
A massive multiplier effect. If you hold a 20-pound box 2 feet away from your chest, the torque generated at your lower spine isn't 20 pounds.
What is it?
Depending on the exact angle, your lower back muscles might have to exert 100 to 150 pounds of counterforce just to act as the other side of the seesaw and keep you from falling face forward.
Wow.
You're demanding an astronomical amount of tension from muscles that just aren't designed for it.
That is wild. So an extra foot of distance turns 20 pounds into 150 pounds of strain on the spine.
Exactly. But bring that box flat against your chest, and the center of gravity of the box merges with your own body's center of gravity.
So the lever arm shrinks.
It essentially shrinks to zero. The rotational torque disappears, and the 20 pounds of weight is transferred vertically, straight down your spine.
Down the sturdy pelvis, down the thick femur bones, and into the floor.
Yep. And there's one more cardinal rule of lifting. Avoid twisting your body while you work.
Oh, yeah. If you need to turn while holding that box, you do not twist your torso. You pick up your feet and pivot your entire body.
Because twisting the spine while it's compressed under a heavy load is basically wringing it out like a wet towel.
Yikes. That sounds painful just thinking about it.
It is the single fastest recipe for catastrophic shearing disc injuries.
Right.
The spine can compress and it can twist, but doing both simultaneously under a heavy load destroys the fibrous rings of the intervertebral discs.
It's all about respecting the engineering of the framework.
Absolutely.
So once we thoroughly understand the mechanical rules of how we move, we need to explore what happens when we intentionally push those mechanics to their absolute limit.
Right. Through exercise.
Which brings us to a fascinating biological distinction. The difference between just being active and actually exercising.
Right. From a physiological standpoint, there is a very clear boundary between baseline activity and true exercise.
What's the baseline?
Baseline activities are clinically referred to as ADLs, activities of daily living.
Things like standing up from a chair.
Or walking at a casual pace around your kitchen. Or lifting a light bag of groceries out of the car.
It's the bare minimum physical activity required just to maintain your baseline existence in the world.
It keeps the engine idling, but it doesn't upgrade the engine.
But exercise is a whole other beast entirely.
Exercise is defined specifically as physical exertion that produces health-enhancing benefits.
So it has to actually improve things.
Right. It requires pushing the body purposefully beyond that baseline idling state. And physiologically, we break down the physical stress of exercise into 3 distinct categories based on exactly how the muscles and joints are engaged.
Okay, let's go through them.
First, you have isometric exercise. This is muscle contraction without any actual motion.
Like pushing your hands as hard as you can against a solid brick wall or holding a plank position.
Perfect examples. Your muscles are fully engaged, the muscle fibers are firing, they're burning through ATP and consuming massive amounts of energy.
But the angle of the joint isn't changing.
Exactly. The muscle length stays the exact same. This is incredible for developing core stability and strengthening specific muscle groups without requiring any equipment or stressing the actual joint capsule.
Okay, what's next?
Next is isotonic exercise. This is what most people picture when they think of working out.
Moving weight.
Yeah. This is movement where the joint opens and closes, and the muscle actively shortens and lengthens while under continuous tension.
Lifting free weights, doing push-ups, running, or doing squats.
Yes. You are using body weight or an external weight as resistance and pulling it through a full range of motion.
And the third one.
Finally, there's isokinetic exercise. This involves specialized computerized apparatuses.
Like those huge machines at the gym?
Well, more like those highly complex resistance machines you usually only see in professional physical therapy clinics or high-end sports training facilities.
Oh, okay.
They provide a dynamic, mathematically consistent resistance throughout the entire range of motion. They perfectly match the force you apply, so the speed of the movement never changes.
Oh, that's really cool. And to make sure that isotonic or isokinetic movement is actually pushing you out of that baseline ADL zone and achieving that health-enhancing benefit, The physiological protocols provide some very specific math regarding the heart.
Yes, heart rate math.
Because it's not enough to just move. You have to stress the cardiovascular system. To find your maximum heart rate, which is the absolute fastest your heart can beat before it stops filling with blood properly, the standard scientific generalization is to take the number 220 and subtract your age.
So if you are listening to this and you are 50 years old, your theoretical maximum heart rate is roughly 170 beats per minute.
Right. But obviously you don't want to be redlining your heart at its maximum the entire time you're on a treadmill.
No, definitely not.
The goal is to hit your target heart rate zone. For moderate intensity exercise, the sweet spot is between 50 and 70% of your maximum.
And for vigorous intensity exercise, you push that up to between 70 and 85%.
So for our 50-year-old listener with a max of 170, a vigorous, sweat-inducing workout means keeping their heart rate consistently around 128 to 140 beats per minute.
And the established guidelines for exactly how much of this stress we need to stay healthy are quite clear.
What are they?
For children and adolescents, the biological requirement is 1 hour of physical activity every single day.
A full hour.
Yes. And the vast majority of that should be aerobic. Getting the heart rate up, with vigorous intensity muscle and bone strengthening activities incorporated at least 3 days a week.
Okay, and for adults?
For adults and older adults, the maintenance goal shifts to 150 minutes a week of moderate intensity or 75 minutes of vigorous intensity.
Plus muscle strengthening.
Yes, dedicated muscle strengthening at least 2 times a week.
Which honestly, when you strip away the intimidation factor, 150 minutes a week is just about 20 to 30 minutes a day of brisk walking.
It's very doable.
But I want to dig into the actual biology of this. Why is this specific type of physical stress so vital?
What's fascinating here is the deeply paradoxical nature of exercise at a cellular level.
Paradoxical how?
Well, we culturally think of exercise as building the body up. We say we're building muscle.
Right.
But mechanistically, biologically, exercise is the deliberate, calculated process of breaking the body down.
Breaking it down.
Yeah. When you are lifting heavy weights, doing rigorous isotonic movement, you are placing so much mechanical stress on the muscle fibers that you are literally causing them to snap.
Oh.
You are creating thousands of microscopic tears in the sarcomeres, which are the fundamental units of muscle tissue.
So you are intentionally injuring yourself. That is the literal definition of trauma.
Yes.
And that's exactly why it hurts so much the next day.
Exactly. That delayed onset muscle soreness, DOMS, is the physical sensation of cellular breakdown and the localized inflammatory cascade that follows.
Immune cells rushing in.
Immune cells rush to the damaged tissue, fluid builds up, and it aches.
Yeah.
But the human body is an incredibly adaptive, survival-driven machine.
Right.
Its response to that microtrauma is purely defensive. The body's central nervous system essentially registers the damage and says, okay, I was structurally compromised doing this specific task.
Yeah.
I need to rebuild this tissue.
And make it stronger.
Exactly. I'm not just going to repair it to baseline. I'm going to rebuild it thicker, denser, and more resilient so that the next time I face this exact level of stress, I don't sustain damage.
That is such a profound way to look at it. It reminds me of the Japanese art of kintsugi.
Oh, where they repair broken pottery with gold?
Yes. Making the repaired seem stronger and more prominent than the original clay. The rebuilding process is a defensive response to trauma. You have to break the muscle to force it to armor itself.
That is a beautiful analogy. The breakdown is the stimulus, the repair is the armor.
Which explains why resting is so important.
That's exactly why rest, deep sleep, hydration, and dietary protein are so absolutely critical. You do not build a single ounce of muscle in the gym, you only destroy it in the gym.
Wow.
You build the muscle in your bed while you sleep and recover from the trauma.
You know, thinking about all this intentional microtrauma, it makes me really wonder about the cultural shift we are seeing in youth sports.
It's a huge topic right now.
Because if exercise is literal structural damage, we currently have middle schoolers, 12 and 13-year-olds, engaged in serious, heavy powerlifting programs for sports like football and wrestling.
It is a highly debated and complex biological issue. On one hand, building the neurological habit of exercise early is fantastic for lifelong cardiovascular health.
Right, setting good habits.
But heavy resistance training, maxing out on squats or deadlifts in very young adolescents, carries a disproportionately high risk of permanent injury.
Because they're still growing.
Exactly. We have to look at pediatric anatomy. Their muscular and skeletal systems are not miniature adult systems. They are fundamentally different.
How so?
Specifically, their tendons, ligaments, and the epiphyseal plates, the growth plates at the ends of their long bones, are still incredibly immature. They are soft, cartilaginous, and actively growing.
So their bones and connective tissues are more like taffy compared to the rigid steel cables of an adult.
That's a great way to put it. They are simply not biologically engineered to handle massive, heavy isotonic stress.
Because if an adult lifts too much weight, the muscle tears.
Right, but if a 12-year-old lifts too much weight, the tension can literally rip the tendon clean off the bone.
Oh, wow.
Or worse, fracture the soft growth plate, which can permanently stunt the growth of that limb.
It's that intense societal pressure to build elite athletes before they even hit high school.
Yeah.
If they don't have perfect, flawless biomechanical coordination, if their crane operator isn't fully trained yet, that microtrauma doesn't result in stronger muscles. It results in catastrophic structural failure.
Yeah, absolutely can.
Yeah.
But to be fair to the sports medicine community, if adolescents are lifting correctly, under strict, educated supervision,
High reps, lightweight.
exactly, focusing on high repetitions with very light weights, just to build coordination and neuromuscular control without pushing for maximum resistance. Starting young can safely foster a love of movement that pays physiological dividends for decades.
Okay, so we thoroughly understand the baseline mechanics of movement, and we know how to intentionally, carefully stress the body to force it to armor up. But what happens when external or internal forces steal our ability to move? When the choice is taken away? Let's dive into the physiological roadblocks to mobility.
These roadblocks are categorized into several distinct areas. First, you have simple developmental stages.
Like babies and the elderly.
Exactly. A 6-month-old infant hasn't yet myelin sheathed their nervous system enough to have the neurological coordination or muscle strength to walk,
Right.
while an 80-year-old adult might be facing sarcopenia, which is the natural age-related decline in muscle mass and proprioceptive balance.
Then you have massive lifestyle and environmental factors.
Right. Things like poor nutrition lacking protein or severe obesity placing crushing static loads on the joints.
Or smoking, which destroys the oxygen carrying capacity of the blood, or chronic alcohol use, which degrades peripheral nerves.
Even the physical environment plays a part. Extreme weather, heavy smog, or simply living in an urban neighborhood without safe sidewalks or parks.
Right. If you literally have nowhere safe to walk, your mobility is going to structurally decline regardless of your biology.
Exactly. But then we get into the heavy clinical roadblocks. There are congenital issues, meaning anatomical anomalies present at birth.
Like what?
For instance, syndactylism, which is the physical fusion or webbing of 2 or more fingers or toes.
Okay.
If your toes are fused, your foot cannot splay properly to grip the ground. That radically affects your fine motor coordination, your balance, and your gait.
And what about the hips?
There's also congenital dysplasia of the hip, where the hip socket is too shallow. That means the femur bone is constantly slipping out of joint or improperly formed, making stable walking impossible.
And then there's a massive, daunting list of disease processes that act as biological roadblocks.
The list is long, yeah.
Things like osteogenesis imperfecta. This is the terrifying genetic disorder where the body fails to produce quality collagen.
Right, the flexible protein matrix in bones that keeps them from shattering like glass.
Without it, patients have incredibly brittle bones that can fracture from simply sneezing.
It's awful. Then there is Paget's disease, which involves a bizarre, chaotic cycle of bone loss and abnormal regrowth.
I read about that in the notes.
Paget's is fascinatingly destructive. Think of the bone remodeling process as a highly organized construction crew. In Paget's disease, the crew goes rogue.
Rogue construction crew.
Yeah, they tear down bone too fast and then haphazardly, chaotically throw new bone back together without a blueprint. The resulting bone is enlarged, misshapen, and structurally incredibly weak.
Wow. We also see the inflammatory diseases, osteoarthritis, which is the mechanical wear and tear degenerative joint disease.
Right, the smooth cartilage capping the bones simply wears away from decades of friction, leaving raw bone grinding on raw bone.
But then you have rheumatoid arthritis, which sounds similar but is an entirely different nightmare.
Completely different. Rheumatoid arthritis is not wear and tear, it is friendly fire.
Friendly fire.
It's a systemic autoimmune disease where the body's own immune system malfunctions and actively attacks the synovial linings of the joints,
Causing chronic debilitating inflammation.
swelling, and eventually total joint destruction.
There's also gout, an excruciating inflammatory response caused by a metabolic failure to process uric acid,
Yeah, the uric acid crystallizes in the joint fluid, most commonly in the big toe.
creating millions of microscopic, jagged, needle-like shards that tear up the joint from the inside out every time the person tries to take a step.
It's incredibly painful. And of course, osteoporosis, a severe systemic decrease in overall bone density.
And speaking of bone density, this brings up a deeply misunderstood biological cycle that we really have to explain, the vitamin D cycle.
Oh, this is a big one.
You constantly see marketing campaigns telling people to chug milk and take calcium supplements to protect their bones.
Drink your milk.
Exactly. But physiologically, you can consume all the calcium in the world. You could eat chalk all day long. And without vitamin D, it is entirely 100% useless to your skeleton.
This is a crucial, elegant physiological mechanism. Calcium is the heavy mineral, the raw material your bones need to stay dense and strong. But your digestive tract, specifically your intestines, cannot physically absorb calcium molecules out of your food efficiently without the presence of active vitamin D.
So it's like a key.
Vitamin D acts as the key that unlocks the doors in the intestinal walls to let calcium into the bloodstream.
And how does the body get vitamin D? It requires a very specific sequence of events, starting with ultraviolet radiation.
Right.
You literally need sunshine to have strong bones.
Yes. UV photons from the sun physically penetrate your skin and strike a specific type of cholesterol molecule, chemically altering it into pre-vitamin D.
Okay, then what?
That molecule then travels to the liver, where it gets altered again, and finally to the kidneys, where it is converted into the active form of vitamin D.
Only then can your gut absorb calcium.
Exactly.
If we connect this to the bigger picture, this precise biological chain reaction explains a terrifying phenomenon seen in hospitals. Think about an intensive care unit.
Oh, the ICU.
ICU rooms are highly clinical, enclosed spaces, notorious for lacking natural light. Many deep hospital ICU rooms don't have windows at all.
Right. So a critically ill patient is lying flat in an ICU bed for weeks. They are entirely cut off from the sun.
No sunlight at all.
Their natural ultraviolet light exposure drops to absolute zero. Consequently, within days, their skin stops synthesizing pre-vitamin D. The liver and kidneys run out of material, and active vitamin D levels plummet.
And without that key, the gut shuts the doors. It stops absorbing calcium from the patient's feeding tube or diet.
But the body still desperately needs calcium, right?
Yep.
Not just for bones, but for everything.
Yes, and this is where the crisis begins. The body requires a very precise, very narrow concentration of calcium in the bloodstream for basic life-sustaining cellular functions.
Calcium is what allows nerves to fire. It is what allows muscles to contract.
Crucially, it is the electrical trigger that commands the heart muscle to beat.
Right, if the blood calcium levels drop, the heart will stop. So, the parathyroid gland senses this drop, panics, and releases a hormone that triggers a massive systemic alarm. It says, we aren't getting calcium from the gut, but we need it to keep the heart beating. Steal it from the only storage vault we have, the skeleton.
Oh my God, the body literally starts dissolving its own skeleton to keep the blood calcium levels normal. It's basically like burning the house down just to keep the thermostat at 72 degrees.
That is exactly what happens. The bone cells secrete acid to dissolve the calcium matrix and dump it into the blood.
And this sudden, massive, chaotic shift in calcium metabolism, combined with the total loss of a circadian rhythm due to having no sunlight, contributes directly to profound, terrifying alterations in consciousness.
It is a major driving physiological factor in what clinicians call ICU psychosis or ICU delirium.
The patient becomes paranoid, severely confused, agitated, and hallucinatory. And it's not just because they are sick or on pain meds, it's because the foundational electrical chemistry of their brain and nerves is unraveling from a lack of sunlight and movement.
The literal architecture of their biology is collapsing, and that perfectly sets up the darkest, but without a doubt the most critical part of this biological deep dive.
The cascade.
Because this loss of mobility, whether it's forced upon you by a disease like rheumatoid arthritis, locking up your joints, or simply being confined to a hospital bed without a window, triggers a terrifying full-body domino effect.
Let's look at the true cascade of immobility, system by system. We have to fundamentally understand that the human body evolved over millions of years to be in constant dynamic motion.
We were built to move.
When you force it into extended unnatural stasis, it doesn't just passively rest, it aggressively and actively begins to dismantle itself. It assumes you are dying, and it starts shutting off the lights. Let's start with the metabolic system.
Okay, metabolic.
When you are rendered immobile, your basal metabolic weight plummets. Your body realizes it doesn't need to burn as much cellular energy to move muscles, so it drastically scales back operations. Your appetite immediately decreases.
Which creates a lethal paradox. You're usually in a hospital bed because you're severely sick, infected, or recovering from major trauma like surgery.
Right.
Your immune system and your tissue repair mechanisms desperately need massive amounts of protein, amino acids, and caloric energy to heal the wounds. But your metabolic system, sensing the lack of movement, is sending powerful hormonal signals to your brain telling you that you aren't hungry.
And that eating makes you nauseous.
It's a vicious cycle of malnutrition right when you need nutrition the most. And it shuts down the plumbing, too.
Oh, the gastrointestinal disturbances. Peristalsis, which is the involuntary, rhythmic, wave-like muscle contractions that squeeze and push food through your 20 feet of intestines, relies heavily on the physical bouncing and shifting of your body walking around to help keep things moving.
So when you lie flat, peristalsis slows down drastically.
The food just sits there, the intestines extract more and more water from it, and it turns into hard, impacted, severe constipation.
Which can actually lead to a ruptured bowel if ignored.
And then, as we just touched on with the ICU scenario, there is the shocking reality of what immobility does directly to the skeleton, even without the vitamin D issue.
Yes, this is an aggressive mechanical breakdown. As we mentioned, bone is living, dynamic tissue. It is constantly, every second of every day, being broken down by cells called osteoclasts and rebuilt by cells called osteoblasts.
This delicate balance of destruction and creation is dictated entirely by physical stress.
It's the use it or lose it principle at a microscopic level.
Exactly. When you stand up and walk, the physical impact of your feet hitting the ground sends mechanical vibrations and microscopic bending forces up your leg bones and spine.
And the osteoblast cells feel this mechanical stress. They say, we are bearing heavy loads. We need to lay down more calcium. We need to stay dense and strong to support this weight.
But when you lie in bed for days, that vibration signal completely vanishes. The body is incredibly ruthlessly efficient. It refuses to waste energy maintaining dense, heavy bone tissue if it isn't currently being used to fight gravity.
So without gravity, the osteoblasts clock out and go home, but the osteoclasts, the demolition crew, keep working.
They just keep tearing it down.
They go into overdrive, actively secreting enzymes and acids to chew up the bone matrix, releasing that stored calcium directly into the bloodstream.
The clinical term for this rapid skeletal dissolution is disuse osteoporosis, and the end result of that is a nightmare called pathological fractures.
Your bones become so weak, so porous, so hollowed out from the inside that you don't even need to fall down to break them.
The skeletal architecture just fails. Clinical texts detail horrifying instances where an immobile patient's femur or pelvis can literally snap simply from a nurse gently rolling them over in bed to wash their back.
Just the mild rotational torque of being turned on a mattress is enough to shatter a hip.
That is just mind-blowing. The scaffolding dissolves in a matter of weeks. But it's not just the bones. The respiratory cascade might be even faster. Let's talk about the lungs.
The lungs are hit hard.
When you are standing upright, gravity pulls your heavy abdominal organs, your liver, stomach, intestines downward, giving your diaphragm plenty of room to drop and expand your lungs. But when you lie flat on your back, gravity pulls all those organs sideways, pressing them heavily up against your diaphragm.
Right. Because of that physical pressure, you simply don't take deep breaths. You take shallow, rapid chest breaths.
And because you aren't pulling deep columns of air into the lowest lobes of your lungs, the tiny balloon-like air sacs at the very bottom, the alveoli, don't fully inflate.
And this is where the wet balloon analogy comes in, right?
Exactly. Imagine the alveoli as millions of tiny, moist balloons. If you don't periodically blow them up fully, the moisture on the inside walls makes them sticky. They start to collapse and stick together, completely deflating.
The clinical term for this alveolar collapse is atelectasis.
And a collapsed lung sac isn't just useless for oxygen, it's actively dangerous. Because when those air sacs collapse and stick together, it creates a perfect, warm, dark breeding ground.
It does. The lung tissue naturally secretes mucus. When the sacs are collapsed, that mucus can't be coughed up. Stagnant fluid pools in those deflated areas.
Gross.
The natural bacteria in your respiratory tract find this warm, stagnant fluid and begin to rapidly multiply.
Within a startlingly short window, sometimes just 48 to 72 hours of immobility, that localized atelectasis turns into a raging systemic hypostatic pneumonia.
The patient can literally drown in their own infected lung fluids simply because they haven't sat upright and taken a deep breath in 3 days.
Okay, I need to stop and really dig into this next system because when I was reading the cardiovascular changes caused by bed rest, my instincts, my fundamental logic was completely 100% wrong.
It gets a lot of people.
If you are lying down in bed, gravity isn't fighting your blood flow. Your heart is on a perfectly flat plane with your toes in your brain.
Right, no vertical pipe.
It doesn't have to pump blood straight up a vertical pipe anymore. Here's where it gets really interesting. Shouldn't your heart be getting a massive, relaxing vacation? Shouldn't lying flat in bed be the absolute best thing in the world for a tired heart?
It seems completely intuitive, doesn't it? But physiologically, it is the exact opposite. Lying in bed is brutal on the heart.
Brutal.
First, you have to understand venous return. When you're up and walking around, the large muscles in your calves and thighs physically bulge and squeeze the deep veins in your legs.
Yeah, little pumps.
They act as secondary biological pumps, powerfully milking the blood back against gravity to your chest. Your heart relies heavily on those leg muscles to do half the work of circulation.
So when you are immobile in bed, the leg muscles go totally limp. They stop pumping.
Exactly. Suddenly, your heart is completely alone. It has to do 100% of the mechanical work to pull that stagnant blood out of the legs and push it through the system without any muscular assistance. So instead of resting, its workload actually increases.
Wait, I need to push back on the next part, though. The notes say that because of this, the heart muscle physically grows larger. It undergoes hypertrophy. But isn't a bigger muscle a stronger muscle? If a bodybuilder gets bigger biceps, they can lift more. Why is a bigger heart bad?
That's a vital distinction to make. In skeletal muscle, lifting heavy weights builds dense, efficient, striated muscle fibers. But the heart is different.
Okay, so
When the heart is forced to work harder against the stasis of bed rest, while simultaneously not getting the variable high-intensity aerobic stress it needs to stay elastic, the cardiac muscle tissue begins to thicken in a pathological way. It builds bulky, stiff, fibrotic tissue.
So it's not building sleek, efficient muscle. It's building stiff, clunky muscle.
Exactly. Think of a bodybuilder who has put on so much massive, bulky muscle that they're totally stiff and can't actually bend their arms to reach their own back.
Right.
The hypertrophic heart becomes thick and rigid. Because the walls of the heart get thicker, the actual hollow chambers inside the heart get smaller. It can hold less blood per beat, and the stiff walls can't squeeze efficiently. It's a weaker, vastly less efficient pump that requires more oxygen just to survive.
A bigger engine with a smaller gas tank. And on top of that cardiovascular failure, you develop severe orthostatic hypotension.
This is a huge risk for falls.
Because your blood vessels have adapted to being completely horizontal for days, the microscopic smooth muscles in the walls of those blood vessels literally forget how to squeeze.
Right. When you are healthy and you stand up suddenly, baroreceptors in your neck detect the gravity shift and instantly command the blood vessels in your legs to tightly constrict,
preventing all your blood from draining into your boots.
But after prolonged bed rest, that reflex is blunted. The moment the patient tries to stand up, the blood vessels stay wide open. Gravity takes over, a massive volume of blood violently rushes down to the feet, the brain is instantly deprived of oxygen, and the patient blacks out and collapses.
Unbelievable. We've hit the dissolving bones, the drowning lungs, the stiffening heart. Now let's talk about the musculoskeletal changes, which might be the most visually disturbing.
Contractures.
We already mentioned atrophy, the rapid shrinking and wasting away of the muscle mass from sheer disuse. But the concept of joint contractures is genuinely horrifying. We see this in severe stroke patients or patients with traumatic brain injuries who are left immobile. Why do their fingers curl so tightly into their palms?
It's agonizing to see.
The clinical texts mention cases where the contracture gets so severe the fist is clenched so tightly that the fingernails actually have to be aggressively trimmed and padded so they don't dig into and pierce the flesh of the patient's own palm.
This is a devastating, agonizing complication. To understand the mechanism, you have to look at the architectural balance of how our muscles are strung across our bones.
Okay.
Across every single hinge joint in your body, you have flexor muscles, which bend the joint inward, and extensor muscles, which straighten the joint outward.
Biologically, genetically, our flexor muscles are naturally much thicker, shorter, and vastly stronger than our extensors.
Which makes sense evolutionarily.
Yeah.
It's why a fetus is curled tightly up into a ball in the womb. Flexion is the body's natural default resting state.
Precisely. So sitting here right now, keeping your fingers straight or keeping your arms comfortably extended at your sides actually requires constant, low-level, invisible neurological signaling from your brain to the extensor muscles, commanding them to maintain tension and override that natural, powerful urge to curl inward.
So the brain is constantly holding back the flexors.
Yes. When a patient is rendered immobile, especially if they have a central nervous system deficit, like a massive stroke, a severed spinal cord, or a severe traumatic brain injury, that overriding, modulating signal from the brain is completely severed.
It's like cutting the main fiber optic cable from the server room.
The local muscles are left to their own devices, and they default to their factory settings. The dominant, stronger flexors simply win the tug of war. The fingers curl violently into a tight fist. The arms draw up tight and rigid against the chest. The calf muscles contract and pull the feet sharply downward into a permanent tiptoe position.
And here's the truly terrifying part. It doesn't just stay a tight muscle.
It changes structurally.
If a nurse or a physical therapist doesn't manually stretch and pull those joints open every single day, the biology literally alters itself. The collagen fibers inside the joint capsule and the connective tissue encasing the muscle begin to physically shrink, harden, and cement themselves into that shortened, curled position.
It becomes a permanent structural anatomical lock. It is no longer a muscle spasm. The tissue has physically fused. You cannot just unbend it.
Once a true contracture sets in, the joint is cemented. It is incredibly painful for the patient, and trying to physically force the arm or hand open at that point will literally tear the muscle belly in half or snap the bones.
That's why the fingernails growing into the palms is a real clinical emergency for neglected patients. The fist cannot be opened without surgical intervention to literally sever the tendons.
It is a profound failure of care. And if all that wasn't enough, this cascade of immobility fiercely attacks the plumbing and the skin.
The plumbing.
Let's look at urinary stasis. Your kidneys sit in your lower back, and they constantly filter blood to make urine, which drips down tiny tubes called ureters into the bladder.
When you are standing, gravity does the work of pulling that fluid down. But when you are lying flat on your back, gravity isn't helping. The urine has to be pushed horizontally.
Just pools and stagnates in the renal pelvis, the little collecting basin inside the kidney.
And remember the bones. Remember what the osteoclasts are doing. They are dissolving the skeleton and dumping massive toxic amounts of calcium into the bloodstream.
Oh, wow. So the kidneys, doing their job, filter out that massive excess of calcium from the blood. So now you have highly concentrated calcium-rich urine just sitting completely stagnant in the kidney basin because there's no gravity to drain it.
Precisely. The fluid sits there, the calcium precipitates out of the liquid, and it crystallizes. It essentially forms microscopic stalactites inside the kidney that grow into massive renal calculi or kidney stones.
At the exact same time this internal plumbing is failing, the external envelope of the body is dying.
The skin.
The constant, relentless pressure of gravity pushing a heavy, immobile body against a mattress physically crushes the tiny capillary blood vessels in the skin, overlying bony prominences, the heels, the tailbone, the back of the skull, the shoulder blades.
It cuts off the blood supply. The tissue literally suffocates from lack of oxygen.
It suffocates, it breaks down, and it dies, creating deep, necrotic, rotting wounds called pressure injuries, historically known as bed sores.
These wounds can become so deep they expose the underlying bone and cause lethal systemic blood infections. And wrapping all of this horrifying physical destruction together are the psychosocial effects. The profound, crushing clinical depression, the loss of bodily autonomy, the isolation, and the sensory deprivation of being locked in a rapidly failing, dissolving body in a single, sterile room.
It is an absolute nightmare cascade. The body aggressively consumes itself.
And because immobility is so inherently violently destructive, healthcare providers must meticulously assess exactly how much a patient can move and how their nervous and muscular systems are holding up against this gravity war.
Which brings us to the physical assessment protocols.
How do you decode the walk? How do you spot the biomechanical glitches before the cascade becomes fatal?
When a highly trained nurse, physical therapist, or doctor watches a patient walk down a hallway, they aren't just looking at their speed, they're acting as biomechanical detectives.
Looking for clues.
They're looking for specific microscopic glitches in posture and gait that act as blaring distress signals for underlying systemic failures. Let's start with static postures, specifically spinal deformities.
Okay.
The first is lordosis, which is a severe, exaggerated convex curve of the lower lumbar spine. deeply arching the lower back and causing the stomach to protrude sharply forward.
You see that biomechanical shift a lot in late-stage pregnancy or in individuals with severe abdominal obesity, right?
Yes, the center of gravity is violently shifted forward by the weight of the abdomen. To prevent the person from constantly falling flat on their face, the lower spine curves intensely backward to pull the upper torso behind the center of mass, maintaining a fragile balance.
Then there's kyphosis, which is an exaggerated curvature of the thoracic spine, the upper back. This creates a severe hunched or stooped appearance. It's incredibly common in older adults suffering from the disuse osteoporosis we discussed earlier.
Right, because the front edges of their brittle vertebrae literally crush and collapse forward under the weight of their own head.
Exactly, it's a structural collapse. And scoliosis, which is a lateral side-to-side S-shaped curvature of the spine that drastically alters rib expansion and shoulder height.
But the clinical notes also detail some extreme neurological posturing. These aren't just bone issues. These are things you see in the ICU in patients with catastrophic brain trauma, swelling, or hemorrhaging.
Yes, and these are chilling to observe. Clinicians look for decorticate posturing. This is where the patient's upper extremities are flexed rigidly at the elbows, the wrists are curled inward, and the arms are held incredibly tight against the core of the chest, while the legs are extended straight out and internally rotated. This specific posture indicates severe damage to the nerve pathways connecting the brain to the spinal cord.
And then there's decerebrate posturing, which the notes indicate is even more ominous and closer to death.
Decerebrate is a sign of massive brainstem failure. In this posture, the extensor muscles go completely rigid. The arms are pushed straight down and forcefully rotated outward at the sides, the teeth are clenched, and the head and neck are arched severely backward.
These aren't just tight muscles or a patient stretching. These are the raw, primitive, base-level distress signals of a central nervous system that is completely short-circuiting. The local spinal reflexes have completely lost contact with the higher brain. The notes also mention dystonia, which are abnormal, involuntary, twisting muscular contractions that force the body into agonizing, contorted postures that can persist for weeks at a time, often caused by heavy psychotropic medications or basal ganglia disorders.
Let's transition from static posture to dynamic movement, the actual gaits. I want you, the listener, to really try and visualize these in your mind's eye as we describe them, because it paints such a clear, vivid audio picture of how a single neurological or muscular glitch completely changes how a human being navigates the world. First is the antalgic gait,
which is the formal clinical term for a limp. Anti meaning against, and algic referring to pain. It is a protective, compensatory gait characterized by a drastically shortened stance phase on the affected side. You step down onto the sore knee or the sprained ankle, your brain registers a sharp spike of pain, and you instantly, reflexively rush to pull your weight off it and get back onto the healthy leg. The rhythm is entirely asymmetric.
Then there is the propulsive gait. Visualize someone stooped over, shuffling heavily, their head and neck bent sharply forward. The steps are very small, very rapid, but they seem to involuntarily accelerate faster and faster, as if the person's upper body is falling forward and their feet are frantically trying to catch up to their own center of gravity before they faceplant. You see this heavily in Parkinson's disease.
Exactly. It's a deficit in the basal ganglia causing a total loss of automatic fluid motor control. Then you have the scissors gait. Imagine walking while someone has tied heavy-duty, highly elastic bungee cords tightly between your inner thighs. The legs are flexed slightly at the hips and knees, and as the person tries to walk forward, the extreme spastic tightness in the adductor muscles of the inner thigh violently pulls the legs inward. With every step, the thighs cross tightly over each other in a sweeping, stiff, scissor-like motion.
It looks incredibly exhausting. This is heavily associated with spastic cerebral palsy or severe multiple sclerosis where the nerve sheaths are degraded. There's also the spastic gait, which is a stiff, asymmetrical, foot-dragging walk, usually caused by long-term unilateral muscle contraction on just one side of the body. This is the classic presentation you see in a patient who has survived a massive stroke on one side of their brain. And then there is the steppage gait.
The biomechanics of the steppage gait are absolutely fascinating. This occurs when a patient has developed foot drop, which we discussed earlier as a direct complication of immobility or nerve damage, where the nerves commanding the shin muscles are dead, and the patient physically cannot lift the front toes of their foot upward. Because the foot hangs completely limp, pointing straight down, if they try to walk normally, they will drag their toes on the ground and violently trip.
So the brain has to invent a workaround.
Exactly. To keep from tripping, the patient compensates by drastically exaggerating the lifting of the entire leg. They use their hip flexors to bring the knee extremely high into the air with every single step like a high-stepping parade horse, just to ensure those limp toes clear the floor before slapping the foot flat down on the ground.
Finally, the waddling gait. This is a distinctive side-to-side rolling motion. Normally, when you lift your right leg to take a step, your left hip muscles clench to keep your pelvis perfectly level. But if those pelvic girdle muscles are severely weak, perhaps from muscular dystrophy or severe arthritis, the opposite hip dramatically drops downward every time you lift a leg. You have to aggressively swing your upper body side to side to throw your weight over the standing leg, creating a pronounced waddle. If a nurse observes any of these specific gaits, it is the crucial first step in the diagnostic protocol. But observation isn't enough. They also have to physically measure raw tolerance and cardiovascular strength.
To do this safely, they conduct activity tolerance tests. They hook the patient up to monitors and record their baseline vital signs: heart rate, blood pressure, oxygen saturation, and respiratory rate. Then they have the patient engage in a controlled, continuous physical activity, like walking down the hall or even just sitting up and doing arm exercises. If the patient can sustain 3 continuous minutes of this activity without their heart rate dangerously spiking, their oxygen plummeting, or showing severe respiratory distress, it gives the clinical team a solid mathematical baseline of their true cardiovascular endurance. They also physically assess muscle mass and raw strength, having the patient perform targeted pushes and pulls against the nurse's hands and feet, meticulously comparing the resistance of the left side of the body to the right side to hunt for hidden asymmetrical weakness.
So once this intense assessment is complete and the specific roadblocks, deficits, and risks are identified, the medical team has to intervene. The war begins. We enter the arsenal of interventions. How do we artificially recreate the massive biological benefits of movement? And what physical tools do we use to drag the body out of that deadly self-destructing immobility cascade?
The absolute first line of defense, especially for a critically ill, bedbound patient who cannot move themselves, is therapeutic positioning.
Ah,
And the clinical terminology used here is incredibly precise because altering the angle of a bed by even 10 degrees drastically alters the internal fluid dynamics and respiratory mechanics of the body.
Yeah.
You have Fowler's position, where the head of the bed is elevated between 45 and 60 degrees. Semi-Fowler's is a lower, gentler angle, around 30 degrees, often used for resting or feeding to prevent aspiration. And then High Fowler's, which is cranking the bed up so the patient is sitting almost straight up at a sharp 90-degree angle.
and High Fowler's is the absolute crucial intervention for the respiratory nightmares we talked about earlier, right? The atelectasis and pneumonia.
Absolutely. If a patient is drowning in their own fluid or having a severe asthma attack, laying them flat is a death sentence. By immediately sitting them straight up in High Fowler's, gravity forcefully pulls the heavy liver, stomach, and intestines downward, pulling them completely away from the diaphragm. This instantly drops the floor of the chest cavity, allowing the lungs maximum vertical space to fully expand and pull in oxygen. There's also the orthomaic position, which is an extreme intervention. The patient sits at 90 degrees, but leans their upper body heavily forward over an overbed table, resting their arms on pillows.
Why lean forward?
Because leaning forward completely changes the biomechanical leverage of the chest. It locks the collarbones and shoulders in place, allowing the patient to use the accessory muscles of their neck and shoulders to literally physically pull their ribcage open and outward.
Yeah.
You see this naturally in people suffering from severe COPD or emphysema. They intuitively adopt this posture just to survive.
The intervention notes also list lateral, which is side lying, to relieve pressure on the tailbone prone line completely flat on the stomach, which became incredibly famous during COVID for helping ventilate the back lobes of the lungs. Supine flat on the back, SIMS, a semi-prone, twisted position where the patient lies on their left side with the right leg aggressively flexed up toward the chest.
SIMS is highly specific. Because of the anatomical layout of the large intestine, lying on the left side with the right knee up straightens out the sigmoid colon, making it the perfect position for administering enemas or performing rectal examinations.
And then there's the famous, highly debated Trendelenburg position.
Trendelenburg is dramatic. The patient is completely supine, but the entire physical frame of the bed is tilted like a seesaw, so the patient's head is sharply, precipitously lower than their feet. Historically, 100 years ago, this was the go-to treatment for shock and severely low blood pressure. The logic was that gravity would literally pour all the blood out of the legs and force it down into the brain. The clinical notes mentioned its use has heavily fallen out of favor for that specific purpose, as it drastically increases intracranial pressure and makes breathing incredibly difficult.
but it's still used today in certain abdominal surgeries to let gravity pull the intestines out of the way of the pelvis and to heavily engorge the veins in the neck to help doctors place central 4V lines.
Moving beyond just altering static angles and positioning, the intervention arsenal includes the actual mechanics of motion. ROM, range of motion exercises. Active ROM is when the patient uses their own muscle power to fully flex and extend their joints. Passive ROM is when the muscles are totally paralyzed or the patient is unconscious, and the nurse or physical therapist must physically grab the limb, bear the weight of it, and manually push and pull the joints through their full rotation to prevent those horrific collagen contractures from cementing.
And we use remarkable technology to help with this too. The clinical guidelines describe the use of a CPM machine continuous passive motion. Imagine a robotic, motorized cradle. This is most frequently prescribed immediately after a traumatic total knee replacement surgery. The patient's leg is securely strapped into the padded cradle, the machine is turned on, and a hydraulic motor slowly, relentlessly, continuously bends and straightens the knee joint back and forth over and over again for hours at a time.
It's like putting the lug in an automatic watch winder.
That is exactly what it does. It moves the joint perfectly while the patient is fast asleep or heavily medicated, completely preventing the rapid buildup of fibrous scar tissue and keeping the joint capsule from cementing itself shut during the most critical hours of healing.
This brings up a massive everyday debate in the physical intervention section, and one I think absolutely everybody listening has argued about with a family member or a coach. The application of heat versus cold. It is a wildly common contradiction. A patient brutally twists an ankle or has fresh invasive surgery. The tissue is hot, swollen, and angry, and the patient begs the nurse for a heating pad because psychologically, heat feels comforting and soothing. But biologically, applying heat to a fresh, swollen, acute injury is the absolute worst, most destructive thing you can do.
It's all about mastering the vascular response at a microscopic level. When you apply an ice pack or cold therapy to tissue, it triggers severe vasoconstriction. The microscopic smooth muscles in the walls of the local blood vessels instantly clamp down and violently narrow the pipes. This actively, physically decreases the volume of blood rushing into the area. It prevents excess plasma and fluid from leaking out of the capillaries into the surrounding tissues, which stops the massive, painful swelling. It reduces internal bleeding from torn vessels, and it physically numbs the local nerve endings to diminish the sharp transmission of pain and stop muscle spasms. Cold is the absolute weapon of choice for acute trauma and active raging inflammation.
You are closing the floodgates. But heat does the exact opposite.
Right. Heat triggers vasodilation. It forces the blood vessels to open up wide. This massively increases local blood flow, which flushes the area with oxygen, white blood cells, and nutrients to ramp up tissue metabolism and healing. It relaxes chronically tight knotted muscles and eases old stiff joints. But if you take a heat shed and put it directly on a freshly sprained ankle or a surgical incision, you are throwing the floodgates wide open to an area where the pipes are already broken and leaking fluid. You will massively exponentially increase the swelling, the tissue pressure, and the throbbing, agonizing pain.
The clinical notes also make a very specific point that moist heat, like a warm, damp towel or a hydrocollator pack, is vastly more penetrative and effective for deep muscle therapy than a dry electrical heating pad, which can actually bake and dehydrate the surface of the skin without reaching the muscle. Beyond thermodynamics, we have the external mechanical tools, the crutches, the canes, and the walkers. And the exact physics of how to fit and use these devices is surprisingly rigorously specific. For crutches, the top rubber pad absolutely should not be jammed tightly up into your armpit. There must be a strict 2 to 3 finger width gap of empty space below the underarm, with the patient's elbows maintaining a slight flex.
This specific measurement is critical for preventing permanent injury. If a patient is lazy and just rests their heavy upper body weight down onto the armpit pads, the hard rubber will violently compress and crush the brachial plexus, that delicate braided nerve bundle threading through the armpit that we talked about at the very beginning of this deep dive. If you compress those nerves, you will literally cause severe nerve damage, agonizing radiating pain, and potentially temporary paralysis in your arms and hands. The weight of your body must be borne entirely by the muscles of your arms and hands, pushing down powerfully on the hand grips, not hanging from your armpits.
And walkers have a very specific, strict rhythmic cadence to maintain a safe center of gravity. The patient must firmly push the walker forward, all 4 legs at once, step into the frame with 1 foot, step in with the second foot to meet it, pause, and repeat. Do not try to walk fluidly while pushing it like a shopping cart. But the most mind-blowing, counterintuitive intervention rule in the entire curriculum involves the simple use of a cane. So what does this all mean for the listener? Picture this. If I severely injure my right knee, basic human intuition, logic, and comfort says I should hold the cane in my right hand, placing it right next to the painful knee so I can lean heavily on it to support the bad leg. Why do the clinical biomechanics notes insist that this intuitive action is completely 100% wrong and dangerous?
It entirely goes back to the core physics of balance and creating a stable base of support. Let's map out the geometry. If your right leg is weak and injured and you hold the cane in your right hand, what happens when you try to take a step forward with that injured right leg? Your entire body weight and your center of gravity must aggressively shift over to the weak, painful, unstable right side of your body. You have placed the cane right next to the weak leg, creating a very narrow, incredibly flimsy, unstable pillar of support.
You're essentially balancing all your weight on two toothpicks right next to each other. You're just asking to topple over sideways.
Exactly. The mechanical rule is, always, without exception, hold the cane on the uninjured, stronger side. If your right knee is severely hurt, the cane goes in your left hand. Here is the magic of the geometry. When you step forward with the weak, painful right leg, you simultaneously bring the cane forward in your left hand. You have just created a wide, incredibly stable geometric tripod. Your body weight is distributed perfectly between the solid cane on the far left and the injured leg on the right, and that massive weight is entirely supported by the healthy, robust muscles of the left arm and the left torso.
It's brilliantly simple once you actually understand the underlying biomechanics of the polygon of support. But here is the terrifying reality. Even with perfect cane placement, even with continuous passive motion machines churning for hours, even with rigorous, exhausting turning schedules every 2 hours, there are hidden, silent killers lurking deep inside the immobile body, and caregivers must watch for them constantly with extreme vigilance. This is the final and unequivocally the most lethal section of our deep dive.
We have to understand that the major systemic complications of immobility are not just painful or inconvenient, they are rapidly, suddenly fatal if they're not caught in time. And the most prominent, most feared of these is the deep vein thrombosis, universally known in the hospital as a DVT.
A DVT. Let's really slow down and break the exact anatomy of this killer down.
We detailed earlier that lying flat in bed causes heavy blood to pool and stagnate in the deep veins of the lower legs because the calf muscles aren't actively squeezing the vessels to pump it back up. Stagnant, pooling blood inherently likes to clot. It's a fundamental property of plasma. A DVT is a severe inflammation of a deep vein, almost always located in the fleshy part of the calf or the deep thigh, resulting in the formation of a solid, gelatinous clot of coagulated blood clinging to the vein wall. The clinical signs are very specific, but easily missed. A rapid unilateral increase in calf size, meaning only one leg is swollen and engorged, while the other looks normal, accompanied by a deep, localized aching pain, warmth to the touch, and a reddish or purplish discoloration of the skin over the site.
So imagine this highly realistic scenario. You have a patient who has been on strict bed rest for 4 days after a complex abdominal surgery. They press the call button, the nurse walks in, and the patient says, "I have a terrible throbbing cramp deep in my right calf. It feels incredibly tight and sore." Human instinct, the deep empathetic instinct of any caring person or family member sitting at the bedside, is to reach down and firmly massage a sore, cramped muscle to relieve the tension and comfort the patient.
This raises an important question, and it represents one of the most terrifying, deadly traps in all of nursing. Massaging that cramp is the absolute worst, most lethal thing you could possibly do. If you rub or deeply knead that swollen calf, the physical mechanical pressure of your hands will dislodge that fragile DVT clot from the wall of the vein. You have just turned a stationary, localized clot into a mobile, deadly torpedo.
It snaps off and enters the main venous return system.
Yes, the clot breaks free. It travels rapidly up the popliteal vein in the leg, enters the massive femoral vein in the thigh, shoots up into the iliac vein in the pelvis, and enters the inferior vena cava, the largest vein in the body. It flows straight up into the chest, dumps directly into the right atrium of the heart, gets forcefully pumped down into the right ventricle, and is violently ejected out through the pulmonary valve directly into the pulmonary artery. The pulmonary artery branches out into smaller and smaller vessels inside the lungs to pick up oxygen. The solid clot travels until the vessel becomes too narrow, and it violently slams into the wall and gets completely immovably stuck like a cork in a bottle. This catastrophic event is a pulmonary embolism, or PE.
The silent killer strikes. The traffic jam is complete.
It instantly, completely occludes all blood flow to that entire section of the lung. That lung tissue immediately begins to die, and the right side of the heart suddenly faces a massive, impenetrable wall of back pressure and begins to rapidly fail. The patient goes from having a mildly sore calf muscle to violently gasping for air in a matter of seconds. The clinical signs of a massive PE are unmistakable and terrifying. Sudden, desperate shortness of breath, sharp, stabbing chest pain that worsens when they try to breathe, a rapid catastrophic drop in blood pressure as the heart fails, a wildly spiking panic pulse, and hemoptysis, which is coughing up bright red blood from the dying lung tissue. It is a massive code blue medical emergency, requiring immediate high-flow oxygen, instantly cranking the bed into high Fowler's position to maximize whatever lung capacity is left, and pushing aggressive, heavy intravenous blood thinners or thrombolytic drugs to literally chemically dissolve the clot before the heart stops entirely.
And because of this incredibly lethal cascade, the golden rule from the clinical protocols for a suspected DVT is absolute. Never, under any circumstances, massage the leg. If you see unilateral swelling and pain, you elevate the leg gently on a pillow to promote passive, gravity-assisted venous drainage without compression. You ensure there is no tight clothing or direct pressure on the site. You notify the provider immediately, and you anticipate a stat ultrasound and orders for anticoagulants like heparin.
Because a pulmonary embolism is so suddenly deadly, the prevention strategies aimed at stopping DVTs and respiratory failure dictate almost the entirety of a floor nurse's grueling daily schedule. They're fighting a constant, exhausting, minute-by-minute war against gravity and stillness.
The sheer volume of raw physical labor required to keep an immobile human body alive and functioning is absolutely staggering. We're talking about 2 or 3 nurses having to physically grapple and turn a heavy, deadweight, 200-pound adult every 1 to 2 hours, around the clock, day and night, just to relieve the pressure and prevent their skin from dying and rotting into bed sores. Continuously instructing and pleading with conscious patients to try and shift their own weight every 15 minutes.
It involves wrapping the patient's legs in TED hose, incredibly tight restrictive compression stockings that physically force the surface veins to collapse so blood has to travel through the deeper, faster-moving veins, or strapping on SCDs, which are sequential compression devices. These are mechanical plastic sleeves wrapped around the calves that inflate with compressed air and deflate in a rhythmic, undulating wave, artificially mechanically simulating the squeezing, pumping action of walking muscles to keep the blood violently churning so it cannot clot.
And then there's the relentless respiratory prevention, constantly waking the patient up to get them to use an incentive spirometer. This is a clear plastic device with a little colored piston inside. The patient has to wrap their lips around the mouthpiece and suck in as deeply and powerfully as they can to raise the piston and hold it there. The massive negative pressure generated inside the chest forces those millions of sticky, deflating alveoli, little wet balloons deep in the lungs, to forcefully pop open, entirely preventing atelectasis.
And if the fluid is already pooling and the wet balloons are already sucked together, they use a flutter valve. The notes describe it perfectly. It looks like a small, hard plastic horn. When the patient exhales forcefully into it, a heavy steel ball bearing inside bounces rapidly up and down. This bouncing creates intense percussive acoustic vibrations that travel straight down the airway, deep into the lung tissue, literally shaking the heavy, sticky, infected mucus loose from the airway walls, like violently shaking a stuck vending machine, so the patient can successfully cough it up and out.
Add on to that the administration of high-protein, high-calorie, nutrient-dense diets forced through feeding tubes just to keep the patient's starving metabolic engine from desperately eating its own muscle tissue for fuel. When you look at the totality of these interventions, you realize something profound. The nurses, the physical therapists, the techs, they are acting as the patient's skeletal muscles, their firing nervous system, and their gravity all at once. They are manually, through sheer physical force and technology, simulating the baseline movement the human body normally gets entirely for free just by existing and standing upright.
It is a highly orchestrated, physically exhausting, relentless battle against the human body's own natural, hardwired urge to dismantle and consume itself the second it stops moving.
Which brings us to the profound end of this incredible stack of clinical notes. We've traced the astonishing, complex blueprint of human movement, from the living factories of the bones and the steel cables of the muscles, to the delicate, unforgiving, unsung hero of the nervous system pulling the levers. We've seen the incredible biological paradox that exercise must physically, violently break our muscle tissues down in order to signal the central nervous system to rebuild them thicker and stronger.
We've deeply explored the physiological roadblocks, seeing exactly how a simple lack of sunlight in a windowless ICU strips the calcium directly from the skeleton, crashing the internal chemistry and fracturing the patient's mind. And we've walked, step by step, through the terrifying rapid speed at which immobility dissolves dense bone, shrinks and stiffens the heart, permanently locks the joints into fetal contractures, and breeds lethal, ticking time bomb blood clots in the stagnant veins of the calves.
When you really truly absorb the clinical reality of these physiological notes, you realize something deeply personal. For you, the listener, right now, the simple, thoughtless act of standing up from your chair after listening to this deep dive is a profound, miraculous biological victory. Standing up is a literal mechanical command to your skeleton to maintain its dense armor. It is a high-pressure signal to your heart to stay elastic and strong. It is a massive, life-saving flush of oxygen down into the deepest, darkest corners of your lungs.
Movement isn't just a physical way to get from point A to point B to retrieve an object. Movement is the fundamental biological language your body requires
Yeah.
to understand that it is still alive, still fighting gravity, and still needed.
And that leaves me with a final, lingering thought for you to mull over as we sign off. When we look at the macro trajectory of modern human society, it is undeniable. We are becoming increasingly automated, increasingly seated, and entirely screen-bound. We have groceries delivered to our doorsteps, we work remotely from soft couches, our homes are voice-activated so we don't even have to walk to a light switch. Our everyday baseline physical activity is dropping closer and closer to that terrifying state of clinical immobility we just spent an hour dissecting. Are we, as a species, slowly, comfortably engineering a future where the devastating diseases of immobility, the pathologically brittle bones that snap from a sneeze, the weakened, hypertrophic, stiffened hearts, the chronic cementing joint contractures, become the standard, unavoidable condition of the average human? What actually happens to the magnificent dynamic human machine when our relentless pursuit of technological convenience permanently, irreversibly outpaces our biology's fundamental, desperate need to move?
It's an incredibly daunting question. The biology is clear. The body assumes that if you aren't moving, you are dying.
So as you finish listening to this, remember the chaotic, destructive signals firing inside you right now if you are sitting still. Stand up, stretch your arms wide, go for a brisk walk. Force your heart to beat a little faster. Because as we learn from the clinical reality today, stillness isn't always rest. Sometimes, stillness is the final alarm.